For joining us today. Uh, November is World Diabetes Awareness Month, and the theme for the period 21 to 23 has been access to diabetes, with the sub-theme this year being on education to protect tomorrow. People with diabetes have 25 times higher risk of blindness than people without diabetes. But the good thing is that 90% of vision loss caused by diabetes can be avoided with early detection and treatment. So PatientsEngage and IHOPE have come together to help people understand, especially people with diabetes, how they can protect their vision and prevent blindness. We are very privileged to have with us a very esteemed panel, and I will introduce you to them in just a moment. But really, our focus is to how patients with diabetes or pre-diabetes can prevent vision loss or manage their diabetes and their eye health better. Quick reminder, PatientsEngage is an online platform for patients dealing with chronic diseases and their caregivers to share personal experiences, information, and learn from each other as well as from healthcare professionals. Our whole emphasis is that the better informed people are, the better engaged they will be, and the more empowered they will feel in making the day-to-day decisions that they need to make. And also importantly, they will realize that they're not alone. There are other people who are dealing with similar situations. I hope is Indian Health Outcomes Public Health and Economics Research Center. It's an exciting and collaborative interdisciplinary research center that has been set up with a research grant from Wellcome Trust DBT India Alliance through collaborations between LV Prasad Eye Institute, Indian Institute of Management Ahmedabad, and Indian Institute of Public Health Hyderabad. The key focus of the center is big data analysis, health economics, clinical and public health research in eye health. You can check out their website as well. So let me introduce our panelists. We have with us Dr. Padmaja Kumari Rani, who's head Teleophthalmology and Vitreo Retinal surgeon at LV Prasad Eye Institute. We have Dr. Bipin Kumar Sethi, who is diabetologist, cares super specialty hospital, Hyderabad, and is very, very experienced in this area. As Dr. Padmaja told me that he's the teacher of teachers. Dr. Manisha Agarwal is head of department Retina at Dr. Shroff's Charity Eye Hospital in Delhi. And I'm Aparna Mittal. I'm founder of PatientsEngage and moderator for this session. Reminder again to people that this session is for general awareness and does not replace a medical consultation. So please do consult your doctor for specific medical issues. And while we are live on Facebook and YouTube and Zoom here, you can post your questions. We will try and pick up as many as we can. And if we miss them and we catch, if you send them later, we will try and address them as subsequently as well. So do contact us on our social media channels or write to us at editor@patientsengage.com. So let's get started because we have a big panel, good panel, and we have a lot of questions. So Dr. Sethi, thank you. We'll start with you. People are generally now more aware of what diabetes is, but they do not always understand the systemic effects of diabetes and the complications diabetes causes. It's still seen as a disease in itself. So can you explain the effects of diabetes and why there are so many complications associated with diabetes?
Thank you. In a nutshell, diabetes is a condition that is caused when the body does not produce the required amount of insulin. That results in many things, but it's easy to understand and diagnose through elevated glucose levels. If one understands this is enough, but it's also important to know that the type 2 diabetes, which is a commoner variant, is a progressive disease. And if we respond to one kind of medication today, that response is not going to last forever, and that's to be understood. Type 1, on the other hand, they know that they require insulin and they keep titrating the dose. In fact, they are far more engaged than the type 2 diabetics. If the disease is not well controlled, it not only results in high glucose levels, but through various mechanisms, which we need not discuss now, it can damage the eye, the kidney, the nerves, and also predispose people to food diseases, to strokes and to what can be called heart attacks and heart failure. This is the disease in and by itself may be asymptomatic in large number of people. And even when it is symptomatic, wherein somebody has got very high glucose levels causing excessive urination, excessive thirst, excessive hunger, weight loss, a treatment that leads to still dangerously high levels may make the person asymptomatic. So the mere fact that you are not having any symptom does not necessarily ensure that your disease is very well controlled, and it requires to be monitored serially and periodically. Unfortunately, given the disease and the general asymptomatic status of the condition, many people neglect and the glucose levels persist for a long time, and then we end up with some damages. So the care of a diabetic essentially not only includes the monitoring of glucose levels on the immediate basis of the previous 3 months, HbA1c, a lipid profile, but also for complications referable specifically to the eye for today's context, kidneys in terms of the urinary protein losses and the kidney function like creatinine, and many, many other tests. This is a constant engagement. It is not something that is done for 1 month, 1 year, because it lasts throughout the lifespan of the individual, mostly unless the person has taken care to lose a lot of weight and it probably has quote unquote got cured. Coming specifically to what is the discussion for today? Many people, when we ask them to get an eye checkup, they say, no problem. I can see the TV screen, I can read the newspaper, but they don't quite realize that there are 2 parts of the eye which I feel so shy and embarrassed talking about in front of the 2 trained ophthalmologists. And there are 2 chambers. One is the lens, which most people think is the only thing in the eye, but also the screens. We tell people about the projector and the screen in a movie theater, because we are all movie buffs down here in Telangana. They understand this, that if there is a problem with the projector, everybody knows. People start whistling, howling. But if there is a spot on the screen, unless it falls on the crucial areas of hero, or for that matter, heroine's anatomy, you won't quite know. So we tell people that the asymptomatic nature of the disease unfortunately carries to the retina as well. And by the time you get some symptoms there, then it is too late to salvage or restore vision to normalcy. Also, we tell people to get screened for glaucoma, because that's another silent disease which can actually render you blind. Right. So apart from the fact that people have to have this periodic eye checkups for maybe just change of glasses, but they should also have the doctor see the inside of the eye, because many people are misled to go to optometrists alone. Nothing wrong with going to optometrists for change of glasses, but they never have a glaucoma check done. They never have a fundus examination, what we call it. And then it's sort of missed out. We ask people, did you get your eye checked up? He says, yes. So we put a tick there, not realizing whom they have seen.
Right. Thank you, Dr. Sethi. Dr. Padmaja, I think we'll take that discussion further, because as Dr. Sethi said that, most cases the complications set in and people don't take enough action. But we also find in some of the, patients we've spoken with that it was basically a blurry eye or something which kind of made them scared that it was possibly diabetes or whatever. But do they then come to see you for, do you have cases where people come thinking they have an eye condition and then it turns out that it's diabetes? Yeah. And how often does this happen, and what are the actions that they must take?
Yeah, I think there are 2 aspects, Aparna, in this. That one is patients come with an eye problem, and then we detect diabetes, something like an opportunistic screening, where they could come for a cataract surgery, or they could come for examination, and incidentally we find an eye problem as well as diabetic retinopathy, that is the back part of the screen affected. So this is called something like diabetic retinopathy in a newly diagnosed diabetes, because it just has been diagnosed either in our screening program and hospital. In terms of numbers, I would say that in a hospital-based data, we found that 1 in 4 could be were having some diabetic eye disease or diabetic retinopathy in newly diagnosed diabetes. And in a population based also we have done, where we went into the general population and did blood sugars and checked. There also we found that it is around 4%, like 100 people, if we just detect the diabetes, around 4% had actually some form of diabetic retinopathy changes in them. So that means because they didn't even know when they had actually diabetes, because systematic screening for diabetes is not a norm in our population. So that's how it happens.
Right. Thank you, Dr. Padmaja. Dr. Manisha, I know we've mentioned diabetic retinopathy, we've mentioned glaucoma a little bit, but if you can talk about the common eye issues you see in your practice, and for which of these is diabetes a risk factor?
So thank you, Aparna ji. I think the most important thing was highlighted by Dr. Bipin, and that is that we really don't have to wait for any symptoms to be coming if we are a known diabetic, because as sir mentioned, that it is a silent killer, and sometimes despite having diabetes for a very long time, you may actually be totally asymptomatic. So what we basically request every diabetic individual is that please get your eyes screened the moment you realize that you are a diabetic. So you may be totally asymptomatic and not having any visual problems. And that is the best protocol to follow. But having said that, the most common visual symptoms that the patients present to us who are known diabetic would be as simple as having a blurring of vision, very typically complaining not able to read the small print of newspapers. And this is despite having used the reading glasses. Now that is important to differentiate between whether it is a simple presbyopic problem, that is the reading vision problem, which all of us get over an age of 40, or is it something more than that, secondary to diabetes? And how you differentiate it is, again, like sir mentioned, if you walk into an optical shop, routinely we would just get a pair of glasses and we start seeing clear. But if you're a diabetic, there is something called as diabetic macular edema, which is the swelling in the central part of the retina. And that central part of the retina is the most important for reading vision. Right. So the patients usually come and say, my glasses are not working now, and I'm not able to read the newspaper print despite having used the reading glasses. The other symptoms can, of course, be a very frequent change of glasses, which again can be a symptom that your diabetes levels or your sugar levels have not been under very good control. And the way they fluctuate, there is a very frequent change of glasses. And this is because the swelling of the lens in the eye keeps changing with the levels of the sugar levels. So that is another thing to be kept in mind. And the people who are having a more advanced stage of diabetic retinopathy, well, they can present with things like they can suddenly start seeing floaters in the eye, and that could be secondary to a mild bleed inside the eye, and that is because of the development of some new blood vessels in the retina because of the lack of oxygen and blood supply secondary to diabetes. And sometimes even the patients can present with just a sudden blackout, and that could be a massive bleed inside the eye. So these are some of the common symptoms which every diabetic should be aware of, and if they have any such thing, I think the best is to walk up to an ophthalmologist and get a complete eye examination done.
Dr. Manisha, one follow-up, very quick one. You said if your power changes very frequently, so what is the normal that is, that would not be considered very frequent?
So like we become a presbyopic, that means there's a requirement for the glasses, and that usually happens at the age of 40. You would not expect a change of glasses earlier than maybe 3 years or 5 years. There could be a slight change in the glass number, but if it is as frequent as having to change the glasses at least twice a year, I think that itself would be a frequent change of glass.
Okay, thank you, Dr. Manisha. Dr. Bipin Sethi, you had wanted to add something.
Yeah, what I want to say was that what Padmaja ji mentioned and Manisha ji mentioned is that diabetes can be asymptomatic disease. So though the retinopathy and other complications are a function of the degree of poor control and the duration, in a patient who is type 2 diabetic, one doesn't quite know how long he's had the condition. And it's quite common to present with complications referable to kidney, eye, and sometimes the heart as well. But in type 1, we can actually say when the patient became a diabetic. So there are clear guidelines that for type 1 diabetics, they should be screened for retinopathy. I may stand corrected here, 5 years after the onset of the disease or detection of the disease. But for type 2, it is almost at detection that we have to, or at diagnosis. So this is something different. Some people say that my cousin has diabetes, he never tested, but that cousin is type 1 diabetic, he's had diabetes for this 1 year.
Right.
Whereas type 2 people have to have their vision tested. And second thing is that sometimes when there is sudden change in the glucose levels, like somebody comes to a well-meaning person who is managing diabetes and the blood glucose level, let's say, fall from a fasting of 350, 450 postprandial to 100 and 140, excellent numbers. But as Manisha ji mentioned, the lens swells a bit more. And the patient says, what have you done to me? My vision has actually worsened. And they start imagining that they have developed the worst of the complications like retinopathy or maybe maculopathy. This is not the case. We tell those people that don't rush to an ophthalmologist for changing the glasses. Let the sugar level stabilize. Maybe your original glass will do. So some people have had this change of glasses 4 or 5 times without any reason. So we tell people that if there is a sudden drop in your glucose levels, the lens is going to take some time, and therefore you should not change glasses immediately unless you are a jeweler when you might be able to afford it, or a person who is working closely on the screen when it really matters. But otherwise, we tell people that, okay, hold on, wait for some time, and then only change the glasses. So I think this asymptomatic nature of the disease is very important. The periodicity of screening is also important. If your retina people say that your eyes are okay, year after year, people say you can screen once in 2 years also. But the ideal way would be to have at diagnosis every type 2 diabetes. And that's a huge number because number of people who are interested in retina can be counted on fingertips in our own city, which is a huge city. I think apart from this, we have to have not just awareness, but a good kind of system wherein if all the diabetics of type 2 have to be screened for retina, believe me, we don't have the numbers to screen them. So there has to be an increase in the aptitude amongst ophthalmologists to take on these dry subjects, which have been made so nice and elegant by people like Padmaja here and also Subhadra. We know people here, so we can tell their names because it is nothing dry about a subject. When there is, people say that in our part of the country that light a lamp where there's complete darkness. So I think retina is one area which is looking for many lamps.
Right. Thank you. Dr. Padmaja, you wanted to add something?
I just wanted to add one more symptom. And Manisha has told everything. I think sometimes the patients with diabetes can also complain of double vision. And that could be due to, again, it happens because of the blood supply coming down to the nerves supplying the extraocular muscles. So they can have third nerve palsy or sixth nerve palsy like that. And so they can have double vision. So that can be also very disturbing symptom, and which again needs a checkup and then reassurance and again stress on the glucose control.
Right. Thank you, Dr. Padmaja. Dr. Manisha, you wanted to add something?
Yeah, thank you, Padmaja, for adding diplopia also to that list of symptoms. The other thing I just wanted to highlight is that a lot of people have this misconception that if they've been having a very good control of diabetes, they are unlikely to develop diabetic retinopathy. And there comes the relevance of what Dr. Sethi mentioned, that the onset of diabetic retinopathy is primarily related to the duration of diabetes and not the control of diabetes. So the onset is going to be dependent upon for how long you have been a diabetic. But of course, if you've had a good, or you are maintaining a good metabolic control, the progression of diabetic retinopathy, of course, is going to be much slower. So that is something very important to keep in mind.
So that was kind of, I think, relates to my next question, which was, are any of these eye conditions reversible with good diabetes control? Dr. Padmaja, do you want to kind of complete that?
Yeah, I think Manisha just started the chain very appropriately. So
Right.
here I would just say that I think in clinics, both Manisha and myself, we see every day, the patient typically walks in between 40 to 50 years of age and with advanced diabetic retinopathy with blindness in both eyes. And the immediately our question will be, we will be asking is your blood sugars are under control, and is your changes? Then they will say, my blood sugar right now is under very good control. I stopped smoking. I'm having exercise. Everything I'm doing. Why is that I'm having now blindness? So here I want to give the concept that it is very important that what has been your glucose control at the time of diagnosis of diabetes. So this is a forum where we want to tell everyone that once you are diagnosed with the diabetes, you should keep your sugar under control, because otherwise the cells will get damaged, and this is what we call metabolic memory or legacy effect. So if the patient maintains good glucose control at the time of diagnosis, they are likely to have positive impact later, that they will not have complications to diabetes like retinopathy and like that. Whereas the converse is also very true, that if you are diagnosed with diabetes and you don't maintain blood glucose control very well initially, the cells get damaged, and that causes they're having later on, even though they become very good and they're doing everything best, but they are already, the cells have been damaged, and that causes the complications. So I think this is something, this legacy effect or metabolic memory, every patient should understand, and even the treating patients, all stakeholders should understand about it.
Right. Thank you. Thank you so much. So basically what we are hearing is that, and that I mean, I know that's true for retinopathy. Is it true for the other eye conditions like macular edema or glaucoma as well?
Means it's mainly related to the retinopathy and macular edema. Of course, the diabetic eye diseases as such, the cataract and the glaucoma, all these are all incidental. They are all most common causes of visual impairment or blindness. In fact, cataract is the most common compared to retinopathy. So those all in a systematic screening, when we screen, we will be able to screen about it. But in terms of progression of the disease, it is in the diabetic retinopathy and macular edema we observe it.
So in a way, Dr. Sethi, if somebody does not get diagnosed on time, and it's diabetes has been there silently for a long time before they finally diagnose diabetes, does that mean that they can't prevent any of these eye complications and they can only manage it subsequently?
Well, there is, as Dr. Padmaja mentioned, there is a window of opportunity. We don't quite know what that window is. But we now know that the earlier we intervene, the longer we keep the patient under good control, the greater is the likelihood of that patient enjoying a complication-free or a less complicated disease status life. That we know. Also, sometimes we hear from the ophthalmologist, and again, I may be pardoned here, is that go and ask your doctor to control your disease. Vitreous hemorrhage, okay, patient having undergone pan-retinal photocoagulation. What is it that glycemic control is going to do now to the retina? It's like Nawaz Sharif shaking hands with the Prime Minister Modi. Everything that could have been at the time of Jinnah and Gandhi is already over. And even if they shake hands, nothing is going to happen. So at that point of the disease, when there has been advanced complication like say, renal failure, or there is blindness due to this, go and get your disease controlled. That actually what she said makes a difference only to the numbers, but to the outcomes, it doesn't matter. So what happens is that it is true that if you do good glycemic control right in the beginning, or for type 1, which is again a difficult disease and involve them all together, and also type 2. Now we, at least in type 2, have got very good tools which can get people to target without having low sugar reaction, and the patient and the healthcare professionals can be comforted by the fact that you are being treated, but you will never have a low sugar reaction with these medications. And then you maintain that for years together, the chances that this complication will occur are minimized. And as also Padmaji mentioned, and also I think Manisha also indicated, some of these are age-related things. Cataract is going to develop in people like me and everybody else also, but it is faster. in people who are diabetic. Similarly, glaucoma tends to also occur in greater frequency in diabetics, probably maybe because they screen more often. Some of these are not directly a consequence of metabolic control, but retinal complications truly are preventable, and that's the sad part of it, that we have to intervene very early, close to the diagnosis, maintain good glycemic control, and communicate the numbers. If you ask somebody having good control, as Dr. Padmaja said, the good control concept of the patient is quite different from yours. What are your sugars? Around 200 fasting, 304. I'm perfectly controlled. That is nonsense. If you have fasting plasma glucose, which is normal, is about 100, and postprandial usually is below 140. So if your values are say around 100, 110 fasting and postprandial 140, 150, then you have the right to say that my glucose are well controlled. So our concept of control may be quite different and at variance with the patient. You go to your families during, and then they say, why didn't you talk to Bipin? He treats diabetes. No, I don't have to meet him. My glucose is always controlled. So how much it is? 350. I very gingerly ask whether it's post meal. No, fasting. Fasting is 350, and that is supposed to be good control. So I guess we have to communicate these numbers down the line to people, that what you think is good control is because they're asymptomatic. Right. I had a wound and that healed in no time, and therefore my glucose might be under control. So I guess those kind of things also make people think that I'm immune to complications because I'm controlled well.
Right. Dr. Manisha, you have your hand up as well.
So I think Dr. Sethi, Dr. Padmaja, myself, and all of us actually, we are very much on the same page that metabolic control and the management of all the complications, they're going all hand in hand. So when we have the patients even coming with visual problems or with problems like diabetic retinopathy, I think none of us lose the opportunity of reinforcing the fact that any management that we do for your eyes and for visual improvement is going to be a very half-hearted job if it is not accompanied with a good metabolic control. And I'll just quote one example. A few years back, I remember a police inspector walking up to me in my clinic, and he had such a huge level of macular edema that my OCT machine was not even able to capture it. Right. And when I tried counseling him that, it's no point intervening for any, eye management unless or until you get your metabolic control and the other things, well under control. I was told that you just do your job. You are an eye specialist, so you focus and get my eyes treated. You don't really bother for what is my diabetes control and what is the rest of the things. But when I had to really take a stand and tell him that, look here, I'm not going to intervene till I know what is your systemic status. Believe me, after 1 month, that police inspector came back to me and I had to actually, I started questioning, is he the same patient I saw 1 month back? Because there was absolutely no evidence of diabetic macular edema. He was back to 6.6. And I said, what miracle did you do? I have not done any treatment. Did you get yourself treated anywhere else? And to my utter surprise, he actually was put on dialysis in that 1 month's time. And that itself had made the entire edema go out of his retina. So there lies the importance that it's no point really touching these patients without really knowing that what has been the systemic control. And I would take this opportunity that even the vice versa is important, that when these patients are under the care of the physicians and diabetologists, because of more important complications, though I would not say that diabetic retinopathy is less important, but because of the other complications like heart problems, neuropathy, kidney problem and all, somewhere down the line, the diabetic retinopathy has taken a little lesser priority. So we as retina specialists apparently are really waiting that it also comes into that priority list where each and every diabetic is counseled that it is mandatory that you have to get your eyes screened, especially the retina, despite you not having any visual problems. I think that is something which will really help all of us to catch these patients very early, before they really start losing their vision.
Right. Thank you, Dr. Manisha. And this is a question to Dr. Padmaja. Yeah, if a person has diabetes and hypertension, does that increase the risk of eye complications?
Yeah, I think in terms of awareness about diabetes, yes, at least they can do a blood test and they will know about it. And this has become little more commoner, this thing. Whereas hypertension, they might have detected sometimes, and they always feel, if you ask the patient, are you having your blood pressure in control? So unless they feel that unless they're angry or they're getting headache, say, I'm very cool, I don't have any blood pressure. So the thing is that unless they check blood pressure by a machine in an appropriate way, we will not even know. So definitely hypertension is a very important comorbid condition which increases the diabetes complication, especially the retinopathy progression has been noted with the blood pressure progression. And one more important aspect is we were just discussing about legacy effect or metabolic memory for the good glucose control. But unfortunately, the blood pressure control does not have any metabolic memory. So once you have been detected with hypertension or blood pressure, you have to maintain your blood pressure throughout lifetime so that you don't have any diabetes related complications. So it's very important to stress this fact that once you are detected with hypertension, they need to have control. And it is very clearly shown that if they maintain blood pressure levels below 130/85, the need for the diabetic retinopathy complications also have been reduced. Means that the need for the lasers, the need for surgeries have been reduced more than 25%. So it's very important to stress that the hypertension control is required. And in terms of dietary control also, only 5 grams of salt is what is indicated. Whereas patients are, all of us, we will not only have salt-rich diets, but also we will actually have another additional top-up salt also. So it's very important to concentrate on the lifestyle changes along with the medication that is required to maintain the hypertension control.
Right. Thank you. Thank you, Dr. Padmaja. Dr. Sethi, I think Dr. Manisha also alluded to this, that, because diabetes causes so many complications, people are asked to see so many specialists as part of the follow-up. How do you, and typically what is the frequency with which they need to see these various specialists, including ophthalmologists, and how can we make that easier? Because it is burdensome in terms of patient care to have to manage all of these different specialties and keep going for tests, etc. So, how, I know you initially also you alluded to the fact that they say that I can see, I don't have a vision problem, and they choose which ones to go to, but how do you convince them on this? And, what would you want to tell those patients now?
We tell them that we are going to manage your diabetes to the best of our capabilities. Our means ours and the patients. Despite that, some people may get complications, and it is necessary to recognize them early, because then one can intervene and at least retard the progression, be it of the kidney disease or of the eye disease, and just like any other diseases. So we tell them that since it is often the case that they are asymptomatic, one has to screen. People know that, and sometimes they forget when is that to be done. So we try to tell people that during everybody celebrates their birthdays. If you don't, your children celebrate. Around your birthday time annually, you have a screen for your kidney, your eyes, and that's okay. At least that will ensure that on a particular date or a particular month, every year, they are going to do it. Because many times, to be fair to all the clinicians who are managing diabetes, is that they may also forget when it was last done. And if it is to be done annually, which is usually the case for some people who don't have a complication, otherwise, if they have a complication, based on the requirement, it may be every 3 months, it may be every 6 months, but people who are actually not having any complications or who have got mild or what are called non-proliferative diabetic retinopathies, annual screen is enough. So as a reminder, it might be okay to have that tested around the birthday or any other occasion which they choose. But I think for a clinic, as a clinic facility, we tell people that around your birthday, you get your screening done, so that they would do it. If they forget it, they will do it 5-10 days here and then, because nobody might visit a doctor or on his or her birthday because it's considered that it is inauspicious or so. But we have to insist on the periodicity and also the consistency with which it has to be done. And we don't scare them, but we tell them that we are trying to prevent this but we want to see the success of it. It's like children have annual exams for the grading. Why? They have passed the quarterly, they have passed the half yearly, but for promotion to next grade, they have an annual exam. So we tell them that we have been doing well, we've been checking your glucose levels, we've been checking your lipids, we want to see how we've done. We would know it annually, so get it done annually. So I know it doesn't work in every patient, and the language that we use depends upon the patient's educational status, understanding. But this is sum total of what we communicate to people.
Right. Thank you.
The symptomatic nature of the disease, the fact that it can progress, also the idea that it gives us about other complications. Let's say that somebody has an eye complication like retinopathy. We become doubly concerned about blood pressure, as Dr. Padmaja said, and also about the kidney function. We have to screen for nephropathy because all nephropathy patients, if they have retinopathy, that means it is diabetic. But if the retinopathy is not there and the kidney problem is there, that it could be that it's not even a diabetic kidney disease. We may have to think quite differently. So retina gives us an information about the disease being caused by diabetes or searching for other treatable causes. So I guess the language that is used may be different in different clinical settings, but we have to outline these various factors and the importance of frequent testing.
Right. Thank you. Thank you, Dr. Sethi. Just a reminder to our audience, we're talking to Dr. Bipin Sethi, diabetologist. We're talking to Dr. Manisha Agarwal, retina specialist at Dr. Shroff, and Dr. Padmaja, also retina specialist. So if you have any questions, please do put them on the chat. We started getting a couple of questions. We'll come to that in a minute. I think pretty much everybody has actually said that the best way to control it is early on. Once you are diagnosed with diabetic retinopathy or with diabetic macular edema, is the progression of that manageable? So Dr. Manisha, if you can talk about the best way to manage that such that you still maintain as much of your vision as possible.
So in terms of progression of diabetic retinopathy is concerned, of course, the foremost, would be the metabolic control, which has to be very much kept under a strict control because it is going to be progressing much faster if the metabolic control is poor. As far as the eye management is concerned, I think it's extremely important that you get your regular checkups done. Based upon what is the stage of the diabetic retinopathy, your eye specialist is going to recommend the management in terms of laser treatment or some kind of injections which are given in the eyes to control the macular edema, or any other intervention in terms of a surgical management. But I think the most important to avoid a progression would be to get a regular checkup done and to be very much compliant with whatever management and treatment is advised to you.
Right. Thank you. Dr. Sethi, does the lifestyle management advice, which is typically given to a diabetes patient, does that change once they have eye complications, or is it the same?
Well, largely no, except when you have got proliferative diabetic retinopathy. Because there, as Dr. Manisha alluded to, the vessels are abnormal. They are not having the same kind of vascular strength, and they tend to bleed, and they're very friable. Somebody who's got proliferative diabetic retinopathy and who starts jogging, running, and jumping, that is the best way to ensure that vessel ruptures. But otherwise, if you have got no retinopathy, or if you have got, let's say, a non-proliferative diabetic retinopathy, then there are no differences in the diet, there are no differences in the exercise. One point which I learned from Padmaja, though it was there in the literature, was that every diabetic retinopathy patient should be on fibrates, phenofibrate.
Sorry, can you explain that in layman's terms?
Yeah, there is a lipid-lowering agent called phenofibrate,
right,
which was found to be of use in preventing the progression of certain forms of retinopathy. So it is essential that all patients who have got retinopathy receive this drug irrespective of their lipid status. So that is something which we recommend to people after having learned from experts like her. What happens is this fragmentation of knowledge. This study was published and then they said there was a benefit in retinopathy, but then we just read it and then forgot about it. Till people like her pointed out that why don't you put your patients on this? Because apart from glycemic control, blood pressure control, smoking cessation, if we had one more agent, it's like we are trying to do our bit for what essentially is slowly smoldering and a progressive disease.
Right. Thank you. I think that is very important as well. Just on that, I know you talked of exercise for, and I think exercise, even weights is a problem or not. I know we talked of jogging, etc.
Any strenuous exercise, any exercise wherein you have got isotonic exercise, wherein you are sort of straining, like weightlifting and things like that, those exercises are not so good. But if you do not have proliferative diabetic retinopathy, or if you had a proliferative retinopathy which has been adequately treated, then I think you can go. But before initiating exercise, we often tell people who have never exercised well to rule out a cardiac condition and also proliferative diabetic retinopathy.
Right. I think there was a question on eye floaters, Dr. Padmaja. I know you answered that in the chat, but if you can talk about that as well.
I think eye floaters, and also just want to tell one more point about exercise is about the breathing exercises. So there is a tendency, especially in a patient with either severe diabetic retinopathy or proliferative diabetic retinopathy, and if they see TV and yoga, and then if they do Anulom Vilom pranayams and then severe Kapalbhati exercises where they're thinking that it will improve the oxygenation, sometimes anything which can cause pressure above the head level, like Dr. Sethi said, sometimes they come with a vitreous hemorrhage. So, and this is a very common occurrence. We do see in our clinics that what is that exercise you have done. Or proliferative diabetic retinopathy, which is unstable. Again, suddenly the patient might have started, So it's very common question for us to ask, are you doing any pranayam? And then gentle pranayam, gentle breathing is fine. But, when there are vigorous exercises to improve the oxygenation, it can have a converse effect. So a moderate exercise of walking with a good foot care, because they also have neuropathy problems, probably around 30 minutes a day is what is actually the best for the lifestyle change that they can brought upon. In terms of eye floaters, actually it can be two types. One can be a floaters which can just occur like eyes like camera, retina is like film. You have a gel which can have can be liquefied and it can appear like a floaters. So which can be just age-related kind of a change. But whenever a floater occurs, it's important that we should have, if they are a diabetic or even if they don't have diabetic also, it's important to have a dilated retina checkup so that we see what is happening once, that is it the gel part which has been detached, and then there are any weak areas, anything in the retina. And then another part is if it is a diabetic patient, whether there are any diabetic retinopathy changes which can cause sometimes bleed in the eye, and that also can cause like a floaters. So even if it is a small floater or a big floater, I think the most important thing is they should have one dilated retinal examination.
Right. Thank you so much. While we said that people with diabetes have 25 times higher risk of blindness, but there's also the study which says that 90% of vision loss can be avoided with early detection and treatment. So I just like to go around the panel and ask how we can achieve this. And I'll start with you, Dr. Manisha. What do you think needs to be done to improve the numbers that are affected with vision loss due to diabetes?
So if we see the statistics, it says that about 42% of the diabetic patients have actually had a very severe loss of vision by the time they walk for an eye examination for the first time. And I think that's a very alarming, percentage of diabetic patients who could probably have prevented that severe loss of vision if they had, undergone an eye examination on time. So I think at the start of this session itself, we all highlighted the relevance that do not wait for any eye symptoms to develop. And as Dr. Sethi very beautifully described, that a type 1 diabetic is having a history of diabetes for more than 5 years, you have to get a retina examination done. And if you are a type 2 diabetic, the day you discover you are a type 2 diabetic, please get your retina examination done. So the most important point that we are all trying to highlight is that do not wait for any eye symptoms to develop, but get a retina examination done. Once you get the first examination done, your eye specialist, he or she will automatically advise you when you need to come back for the follow-up checkup. And if that cycle you strictly follow of going for a regular checkup and taking the advice and being very, compliable with whatever treatment is being advised to you, I think you can surely prevent a severe loss of vision.
Right. Dr. Sethi, what would you like to add?
Well, I think she has covered very important aspects, and I would again reiterate that it is better to diagnose these conditions early to prevent loss of vision. Because if you have lost some vision because of any of these diseases, it's unlikely that it gets restored. If you are, let's say, at some level, you have the Stellen's chart, you are reading at, say, 6/6, and your level comes to 6/9, it's unlikely that you'll go back to 6/6. You might stay at 6/6, but you might even go to 6/12. So the progression of the disease is more. And again, we tell people that once there is a damage to the eyes, it is not going to settle at a level that you want it to. It will settle at a level that it has to. So the best time to intervene is when there is an early disease which can be handled. So that let's say that somebody has got very early changes, 1 or 2 microaneurysm, which are some spots, and then this person gets a little bit alerted and starts controlling his disease better, blood pressure better, then this person is obviously going to look after his eyes much better. And it's, even if he gets the disease progression, it will be at a stage that can be handled, not at a very late stage when very little can be done.
Right. And Dr. Sethi, as far as that is concerned, there are now many more, because there are, there's an audience question that's come in, that if I manage using a CGM, continuous glucose monitor, etc., does that improve my control and will that prevent blindness?
That's interesting. It depends on what you do with that. We have patients who do continuous glucose monitoring, and then they have graphs on which no action has been taken.
Right.
So we tell people that it's as good as not having done anything. Similarly, people who do their finger sticks, they come after 6 months saying that, oh, you didn't see the report in January 2019. What will I do with the January 2019 report? When you have not done anything. So it's like, we tell people jocularly, it's like I went out for a holiday, which I seldom do, and I told Padmaja to look after my house. And when I come back, I find that there's nothing in the house. But Padmaja says, in January, somebody took the refrigerator, February, the fridge, the TV, March, the bed, then the nuts and bolts in the gate. You asked me to just observe, not act. So somebody doing the CGMs and all that, very good. If you are acting on the aberrations, if you are doing nothing about it, it's just like Padmaja watching my house being looted and doing nothing about it.
Dr. Padmaja, your reputation is at stake, but Dr. Padmaja, anything else you would like to add?
I just want to add that definitely now we have very objective ways have come into place in the screening. So I always feel that the integration at the point we need to achieve in that direction where the patient should ask for the screening for retina, either in the form of a photograph or at the physician site, along with the battery of investigations. How that make it possible, we have to look in that direction, because we have now portable cameras are available, which can take a simple photograph. At least a kind of awareness will come that, okay, there are some changes which probably requires him to go into the next level. So that is something we should definitely work in that direction, because there are battery of investigations investigations that are asked at the physician site. Definitely, if a camera is there, and also a technician, our vision technician or an optometrist also can manage that cameras along with some kind of a refraction and vision check and then photograph. That kind of a service, if it becomes a part of physician clinics and as well as diagnostic labs, wherever the diabetic patient most walks in, and also pharmacies, these are the places where we should look at the opportunity to screen early.
So is there any initiative happening, Dr. Padmaja, on adding these screening options elsewhere as well? Because as Dr. Sethi earlier alluded, that people have to come to ophthalmologist or a retina specialist. So are there other options now available where an optometrist will have the necessary screening option, for instance?
So we have beautifully demonstrated in various project modes. And also right now, the cameras are getting integrated in the primary health centers and all. But as Dr. Sethi said, unless someone acts it and utilizes, and it is like, you have another investigation. Like, for example, if I keep one camera in Dr. Sethi's place, but I don't have any technician or the source or the optometrist, you cannot expect a physician to, take care of the whole process. So we need to kind of an integration is what is required.
Right.
Along with the service as well as the service care provider. Yeah.
Right. Dr. Manisha, you wanted to say something.
So just to add to what Padmaja has highlighted, I think it is time now that DR screening becomes very much a part and parcel of every physician and diabetologist. And in today's time, you really don't need to wait to go to an eye hospital or an eye specialist. But you also have these artificial intelligence-based cameras, which are non-mydriatic cameras where you don't need to dilate the patients. And it's hardly, we have cameras, we have been doing a lot of active DR screening is being done on behalf of Retina Society of India, where we screened all the Delhi police officials. And also we went and screened the military men in the Jammu military hospital and the BSF Jawans in Gujarat. And believe me, it is as simple as that you have a click and within 2 minutes, the report reaches the mobile phone of the patient or the person who has been screened. And it is a report which is generated, which tells you that do you have any evidence of diabetic retinopathy or not? And if you do have, then it is good that you go and get yourself, checked by a retina specialist or an eye specialist. So a primary screening, just to be highlighting whether you have any evidence of DR screening, is just a 2 minutes job now and can be very much catered to, like Padmaja mentioned, in any blood diagnostic labs or in any of the physician or diabetologists. And as far as the awareness is concerned, just to share this interesting data that I recently attended one conference of diabetologists, which was recently held in Chennai. And there was a stall with a non-mydriatic camera, and they were just screening all the diabetologists who were attending the conference. And in one day, they had screened 75 diabetologists, out of which 25 had DR and they were not aware of it. So, that is where I'm coming from, that we really do not, all of us would not make that effort of walking to an eye hospital unless or until we start having certain symptoms. So it has to be an opportunistic screening. A diabetic has to go to the diabetologist, has to go to the physician, and it is a very small investment. And now even Ayushman Bharat, interestingly, has started giving reimbursement for DR screening, which is going to be done not only by the eye specialists, but also by the physicians and by the diabetologists. So earlier, a lot of people felt, why should I really be putting in my time and effort in doing DR screening? But now you do have an incentive attached through Ayushman Bharat, where you are going to be able to reimburse the bill and get a reimbursement only for DR screening, which can be done both by the diabetologist, physicians, and by the eye specialist. So I think there where the importance of DR screening is now catching on and is becoming a priority at every level.
That's definitely useful. And just does anybody know, and I don't know this, but do the typical packages that are there for diabetes screening, etc., do they include the DR screening?
In all of these? Yes.
But these,
We do have
the
this.
test, the labs that
Yeah.
announce these packages.
No, I don't know about that, but in our hospital, we have a comprehensive diabetes screening, which is done annually, and that includes fundus examination with unit that is affiliated with the LV Prasad Hospital, wherein if there is any lesion that is found, automatically they get a priority appointment with the retinal team. What I was also about to say was somewhat similar to what Dr. Manisha said, that artificial intelligence is going to make a lot of difference in this. It is impossible. It is impossible, I repeat that word, that for the limited number of retinal specialists to screen people, and if these images can be captured by a high quality camera and can be relayed to a center, see, it's not appendicitis that it has to be diagnosed just now. If we can have the data turnaround time you said was 2 minutes, but even if it is 5 minutes, 1 hour, 2 hour, 1 day, it is better to have some idea, and it has to be, I insist it has to be done by someone who is trained in that. See, there's no point in getting the eye examined. I gave an example of an optometrist, but let's say a person is not trained in retina, looking at the eyes of a patient by putting some drops. That is also not good, because the patient feels falsely assured that she has no problem, wherein the person who has seen doesn't actually know what a retinopathy is. So I think we are moving into that era wherein we have the possibility of capturing high quality images, transferring them to a center which analyzes that day in, day out, and then says that, okay, this is what it is, this is what it is, or it requires a better image. Or so what happens is that this is a collaborative work, and we need to talk about this. It's not enough if 4 of us sit here and they say it is important. It's important, and I'm happy to know from Dr. Manisha that it is now reimbursable. That means people are becoming aware and alerted to and realize the importance and value it. So I think these are all issues which over a period of time are going to get better. But I am a big fan of artificial intelligence, and I think that's what is going to make a lot of difference to how these images are captured, analyzed, processed, and eventually reported.
Right.
Just want to add that artificial intelligence part is that it's also important that the people who take the pictures, either it is a technician, an optometrist, they should also know about diabetic retinopathy so that they actually capture the pictures of good quality so that these AI tools work very well. So it's a human intelligence combined with artificial intelligence works very well to actually make the screening pathway robust. And I would say that integration is the key, because 90% of diabetic retinopathy are the complication. 90% of diabetic retinopathy is a mild or moderate form. Only 10% of patients will actually have vision threatening diabetic retinopathy, which requires referral to next level, whereas 90% is going to be actually managed with the systemic control. So it's very important to detect early so that the effect of complications can be done.
Right. So, yeah, I think we have had a great discussion. One final key takeaway or a message to the audience of patients out there, and I'll just go around again. Dr. Sethi?
Well, there is a saying in Sanskrit that of all the Gyanendriyas or Indriyas, eyes are the most important. So I guess that we have spent some time on this, and I think Sarvendriya Naine Pradhanam is what is it. My Sanskrit is as bad as my English. So I think it's important that we respect the eyes because they are a window through which we see the world. And if that is gone, then many people would see that everything is gone. So I guess having known this through ages and sages, we need to do something about it rather than, have this rhetoric that eyes are important. What are you doing about the eyes? So I think this is a good platform. And I'm so happy that you took time to tease out the various nuances around the eye disease in diabetes. And if the viewers get influenced by this, then I think the purpose of this meeting would have been greatly served.
Thank you. Thank you, Dr. Sethi. Dr. Manisha, the final message or a key takeaway?
Yeah, so I would totally agree with Dr. Sethi that to keep an eye on what's going around you. If you're a wife, you have to keep an eye on your husband. If you are the husband, then you have to keep an eye on your boss. So you have so many things to keep an eye on. And to keep an eye on other things, well, you have to keep your vision in very good condition. And to have your vision in good condition, especially if you are a diabetic, I would just request all that do not wait for any visual symptoms to arise for you to really consider going for an eye checkup. The day you have been diagnosed to be a diabetic, please get your eyes checked, and that includes a complete retinal examination, and be very regular with your retinal examination and eye care. And that is extremely important to have a very healthy and a happy life throughout.
Right. Thank you. Dr. Padmaja?
Yeah, I think the key messages are all has been told very nicely. I agree with all of them. Along with, I would say, we should definitely integration is the key, and then one-stop care solutions we should look forward, because with the technology and teleophthalmology and all those things, patient actually probably need not even move to different places. Whether the patient is seen in a physician clinic or an ophthalmologist clinic, we should be able to, with using the photography and fundus photography, we should be able to give their care that is required for the patient. So I think we should look for one-stop care solutions. And of course, with integration is the key.
Right. Thank you. Thank you so much, Dr. Sethi, Dr. Manisha, Dr. Padmaja. I think the message is quite crystal clear to our audience that, you must take care of your eyes. You cannot neglect your eyesight or your vision. And you should, if you are diagnosed with type 2 diabetes, at the same time, please get your eye checkup done properly, not just to walk into an optometrist. Make sure that it's a proper retina screening. And the best way to manage that is early. So do take action. And as Dr. Sethi said, that ultimately all the data in the world is not enough if you're not going to take action. So do make sure that you actually take action based on this information. And as Dr. Sethi said, that even type 1 diabetes are more likely to take things manage it well. But in case you're not aware, please do make sure that you're managing that well as well. And while the risk of diabetes is high, the risk of blindness is high, but it is preventable. So please do, remember that, and don't lose hope as well. Thank you so much. Also, I think the point that we need to make sure that access is available closer to the patients as well. So I think there are some such systemic changes that are happening, and that's good news. And we should continue to work towards that. Thank you so much, everyone, for your time.
Thank you.
Thank you.